Dr. McGee, I believe we have critical mass if we would like to get started.
Great, thanks, Doug. Welcome all the OPTN board directors, as well as the general public that has joined us to the June 18th meeting of the OPTN Board of Directors. The first item is we're going to call for a quorum. That link is now in the chat.
I ask all board members to please click on the link in the quorum link in the chat to acknowledge your presence. And once I get that confirmation from the team.
Hi, this is Jim Case, and I'm in the airport in Boston, but I'm here. I'm here.
Thanks, Jim.
Thank you.
And when we have a quorum, can you please give me the exact number?
Certainly. Dr. McGee, we have quorum. We have 25 present currently.
Okay, and a quorum's 21, correct?
Quorum is 18, I believe. For
18, okay, thanks. All right, so thank you all for joining again. Next slide. Just as a reminder that this is a public meeting, it is being recorded. In the spirit of engagement, please raise your hand if you have a question or a comment. Use the chat feature only to report technical issues. Keep your microphone muted unless you're speaking. Turn on your video if possible. And the closed caption is available if you so desire. Next slide. So the agenda for today is we have two approvals to make regarding prior meeting summaries. Those will be voting actions. We're also going to discuss and vote upon recommendation for an emergency action from the Disease Transmission Advisory Committee. Next, we'll move to the Finance Committee recommendations regarding the 2027 OPTN registration fee, also a voting item. After that, we'll entertain other and new business before the board moves into closed session. Next slide. So the first item of business is approval of two meeting summaries. As you'll recall, our last, we had an ad hoc board meeting, so there are actually two meeting summaries to approve, and they're separated to make sure that anyone who wants to abstain from one does not need to abstain from both. So next slide. So there's a motion we've prepared to resolve that the meeting summary from the Board of Directors meetings held on May 1st, 2026 is hereby approved as presented with authority granted to the Secretary to make non-substantive corrections as may be necessary. Can I have a motion for that?
Move approval.
Thanks, Alan. Second.
Second, Gina.
Thanks, Gina. Any discussion, questions? Doug, let me know if you see any hands.
I see no hands, Dr. McGee.
All right, there's a link in the chat for the vote. Right. Let us know.
Has been approved, 23 approved, 0 non-approved, 0 abstentions. Thank you.
Great, great. So the next resolution is for the following meeting on May 21st, that the meeting summary for the Board of Directors meeting held on May 21st is approved and as presented with authority again granted to the Secretary to make any non-substantive corrections as may be necessary. Can I have a motion for that?
Motion.
Thanks, Gina. Second.
Second.
Thank you, Bill. Everybody. All right. Any discussion? Do you see any hands?
No hands, Dr.
Okay,
McGee.
great. Okay, right. All right.
And the link is now in the chat. If you would like
right.
to click, please, all board members, please click on it and vote. Just waiting for the vote count. The vote carries 21 approve, 0 reject, 1 abstain.
Great, thank you. So the next item is regarding a recommendation for emergency action on behalf of the board from a recommendation from the Disease Transmission Advisory Committee. As the board is aware, that we've been made aware of two donor-derived transmission events, which highlight opportunities for us to strengthen safeguards within the context of living donor transplantation. I'd like to thank Dr. Pouch and her colleagues and our colleagues that are on DTAC for their rapid review and thoughtful work on these recommendations. We're going to first hear Dr. Pouch's presentation again, and we'll then turn it over for discussion. Dr. Pouch.
Thanks so much, Dr. McGee. Okay, I don't know if it's possible to move to the next slide. Okay, so by way of background, and I'll say the discussion today really centers around living donor testing considerations. So with that in mind, the current guidance for screening of living donors mandates that living donors be tested for infectious diseases within 28 days of organ procurement. However, as Dr. McGee noted, there have been two recent donor-derived transmission events, one involving HIV and another involving West Nile virus. And those collectively have highlighted the need for testing closer to the date of organ procurement, again, more closer to organ recovery than the 28 days that are currently outlined in policy. And that's to ensure the safety of organ transplantation from living donors. Next slide, please. With respect to the HIV transmission event, in brief, there was a recipient who underwent living donor kidney transplant who was noted to have developed HIV infection at the time of routine post-transplant screening, as is mandated in OPTN policy. At that time, the HIV viral load was about 163,000. HIV antigen antibody testing around that time was negative, suggesting a really acute infection. Subsequently, pre-transplant, or I should actually note that pre-transplant HIV testing was negative for both the donor, and that was done using HIV antigen antibody testing and nucleic acid testing, all of which was done more than 14 days prior to transplant, and pre-transplant testing of the recipient, which occurred on the day of transplant, were negative. Subsequently, testing a bank donor serum from the day of donation was notable for a negative HIV antigen antibody, but a viral load of 556, and subsequent evaluation of the donor confirmed HIV infection. Next slide, please. With respect to the West Nile transmission event, this transmission event actually impacted a peripheral blood stem cell recipient, which normally does not fall under the purview of DTAC or the OPTN, but I think this case really highlights the testing window that we're considering today. And so this recipient developed West Nile virus infection 17 days post-transplant and subsequently died due to that infection at 43 days post-transplant. Now, pre-transplant testing of the donor using a West Nile virus nucleic acid test did not detect West Nile virus at 28 and 14 days prior to transplant, respectively. However, post-transplant testing of the donor demonstrated seroconversion by IgM and IgG, which supported an acute infection near the time of donation. And while confirmatory testing and additional evaluation is ongoing, I'll just say that the preponderance of evidence at this time does support donor-derived transmission. Next slide, please. So taking into consideration these two recent cases, the DTAC has proposed a policy change relating to both HIV and West Nile virus testing policies germane to living donors, and this would be applicable to OPTN policy 14.4.a. With respect to HIV, the current language states that HIV ribonucleic acid, or RNA, by nucleic acid test, or NAT, be performed as close as possible, but within 28 days of organ recovery. And the proposed change in policy and proposed language would be that HIV RNA by NAT be obtained as close as possible, but within 7 days prior to organ recovery. Next slide, please. Similarly, we have proposed a change to West Nile virus testing policy for living donors. The current language states that living donor recovery hospitals must conduct infectious disease testing for West Nile virus by nucleic acid testing on all potential living donors with a planned recovery date between July 1st and October 31st. These test results must be obtained prior to organ recovery, and testing must be performed as close as possible to the recovery date, but within 14 days prior to organ recovery. And similar to the previous slide, the proposed language would largely remain the same, except the testing for West Nile virus is proposed to be within 7 days rather than 14 days prior to organ recovery. And there would be no change to the seasonal testing requirement as it currently stands. Next slide, please.
Great. And actually, I'll take it over here for a moment, Stephanie. So thank you, Dr. Pouch, for that great presentation. And again, thank you to all the members of the DTAC who voted strongly in favor of this, what we're proceeding with. Before we move to discussion and voting, I want to address some of the feedback we got from the board during our recent initial discussion of this issue. Several board members asked that we obtain some other stakeholder input before considering this emergency action. And in response to that, the chairs and vice chairs from Living Donor, Kidney, Liver, the Transplant Administrator Committee, the Transplant Coordinator Committee were invited to join the DTAC leadership, HRSA and OPTN leadership on a special call on June 12th. Representatives from Kidney, Living Donor, and Transplant coordinators participated directly. Those that were unable to attend received the recording and were given the opportunity to provide feedback. I have discussed these issues with both some of those leaders, some leaders around the country in transplantation, as well as just some members of the public regarding where they thought this would fall into implementation and the need to do this. All the discussion was thoughtful and very focused on patient safety. It was clear consensus, overwhelming, that patient safety is really the issue that should be addressed through this emergency action, and there's really no other alternative. In the eyes of the people that we spoke with, people acknowledge that challenges exist, but we deal with challenges all the time in the transplant system, and they're not surmountable. And should not keep us from addressing a known patient safety risk. I would remind the board too that, as we've discussed previously, and including in the past year, emergency actions on behalf of the board are meant to address issues that cannot be addressed in a time cycle that is appropriate for the normal committee public comment period. As you know, West Nile testing begins July 1, and summer is already upon us. The emergency action proposal the emergency action will go out for public comment within 6 months of it being passed, and it will be responded to. And in response to the board's comments, the resolution language has also been simplified. So the first part of the resolution addresses the policy question before us, which is that whether an emergency action is warranted to address the patient safety issue. The second part gets around questions that were raised about the implementation. Previously, we had some consideration about some specifics, but all resolutions of the board are not tied into an exact timeline of when it will be done. It will rather be done when it can be implemented and operationalized. So that the resolution authorizes the president and/or appropriate designee to work with HRSA and OPTN contractors to develop and execute an implementation plan. We've worked on some components of that, but we're not finished, but we hope to move this expeditiously. So this allows the board to act today on this patient safety issue while ensuring that we implement it in a coordinated and practical manner. So the motion before us is now therefore be it resolved that the board, in accordance with the management and membership policy E.7, hereby approves DTAC's recommended emergency amendment to OPTN policy 14.4A to change the HIV testing window for living donors from within 28 days to within 7 days prior to organ recovery. Resolve further, comma, that the president and or their designees are authorized to direct all actions necessary to communicate, implement, and administer the foregoing resolutions. Can I have a motion for that, John?
Move approved.
Motion, and Alan, a second, and with that,
Yes,
we'll
second.
open it for discussion.
Second, Meyer.
Thanks, Dan. So with that, I'll open it up for discussion from the board. Steve,
I think John is hands raised ahead of me.
John, are you still raised from the motion?
Yes.
Okay, thanks.
All right. I just thank you for all that information. That was very helpful. Just one question. I'm assuming you covered, but I'm assuming when you discussed with Living Donor and other committee heads, you talked about the exact time changes in terms of like going from 28 to 7 days also, and they approved that also?
Yes, we were specific about the 28 and the 7.
Okay. All right. That's what I wanted to know. Thank you very much.
Thank you.
Sorry, John, I did have a question and a comment.
Go ahead, John.
So my comment is I would flip the order and state the requirement first that testing must be performed within 7 days prior to organ recovery and as close to the recovery date as possible. I mean, I would just flip the language. It's a little bit awkward the way it's written. And then my question is, and I'll just preface it by saying, I spent 30 years developing and commercializing diagnostics, including HIV tests and mosquito-borne virus tests. So I understand very well that whether we're talking about nucleic acid diagnostic testing or antibody or antigen testing for either of these viruses, they each have discrete windows of detection. And so my question is, did we discuss, particularly for HIV testing, making it less than 7 days? For example, 5 days to maximize the clinical relevance and to minimize the chance that a donor's infection status changes between testing and procurement.
Yeah, great question. Let me see. The first question really had to do with the window and the duration, and whether 7 days was long enough or not, or short enough, actually. So that was discussed both with DTAC as well as CDC, who we've actually been engaged with this, as well as HRSA. It was felt that the 7 days, while not being perfect, was a very good improvement in things and minimized the risk substantially. So, and there's also nothing precluding anyone from testing at 3 days, but we wanted to keep the window something that could be operationalized with both tests and the West Nile virus. You know, the HIV testing is done in most acute care hospitals and can be done rather rapidly. The West Nile is a little bit more complex, and they thought that 7 days was a reasonable, a very good effort forward.
Okay, thank you.
Yeah, thank you. Nahel.
Thanks, John. My question is to Stephanie. I was wondering about this HIV case you presented. You had the HIV antibody antigen testing, which my understanding is the gold standard nowadays in testing for HIV, was negative on this blood, on the serum that was saved, and only a low level viremia was detected. So my question is we're not specifying what testing is required. I believe both are required if I'm in prior policy. What do you expect the centers to do if they have? I mean, are we looking at a zero transmission? I don't know that that's realistic. And next time we're going to have, you know, to John's point earlier about narrowing the window, yet to John McGee's point, I mean, at some point we gotta, I don't know that we're able to get all of these realistically done immediately pre-transplant, and are we to cancel transplants because of that?
Yeah, so I think, so to answer your question, so the policy currently requires HIV antigen antibody testing as well as nucleic acid testing. for donors prior to organ donation, and so that would remain the same. I think, with any aspect of donor screening, we try to be as accurate as we possibly can be. I think, as we would like to see this kind of situation be a never event. Although, that's, as we all know, it's challenging to make anything an absolute never event. But we did feel that this was a significant issue related to patient safety, and wanted to ensure that that was the primary consideration, knowing that the turnaround time for these tests is, at least it should well be feasible within that 7-day time period. I'll also say that I think, in conjunction with our testing, particularly germane to living donation, is, ongoing opportunities for living donor recovery hospitals to have conversations with living donors about safe living, particularly in between the window from between testing and organ donation as well.
Thanks, Stephanie. Other
And the
questions?
false positive rates for these tests? Are we gonna, there is still part of that as well, right?
That actually is
Yeah.
perhaps one of the advantages of getting the testing at 7 days. If you're worried about the false positives, they could always be retested or investigated. Is that reasonable, Stephanie?
Oh, sorry, I was having trouble with mute. Yeah, I think that is reasonable, given that you have that time window to work with. There was a publication, I believe it was about a year and a half ago, that outlined an individual case in which a living donor had what was ultimately deemed to be a false positive test, which was then kind of reassessed on very thoughtfully, and the case was able to proceed. And I think that, as Dr. Mickey mentioned, I think that is the benefit of having that 7-day window where you have opportunities to reevaluate. As opposed to the deceased donor situation, in which we just don't have the ability to adjudicate, true positives versus potentially, the other scenario.
Right, thanks. And again, there's nothing preventing people from doing it from a shorter window as well. Any other hands or questions?
No other hands, Dr. McGee.
Okay, great. Well, with that, I would call it for a vote, having been motioned and seconded.
The link to the HIV vote is now available in the chat. I ask all board members to click on the link and cast your vote now.
Doug, I vote to approve. It's Jim Kaysen.
Thanks,
Thank
Jim.
you. The motion is carried, 23 approve, 2 reject, 2 abstain. I'm sorry, 2 reject, 0 abstain.
Okay, thank you. All right, thank you. The next motion that we have drafted regards the West Nile virus. So now therefore be it resolved that the board, in accordance with management and membership policy E.7, hereby approves DTAC's recommended emergency amendment to OPTN policy 14.4.A to change the West Nile virus testing window for living donors from within 14 days to within 7 days prior to organ recovery. Resolve further that the president and/or his designee are authorized to direct all actions necessary to communicate, implement, and administer the foregoing resolution. Can I have a motion?
Motion.
Thanks, Sam.
Second.
Thanks, John. It's now open for discussion. Dan.
Just a simple question. What did you say again about with these emergent amendments in terms of the public comment?
So
That's
so
okay.
they have to go out for public comment within 6 months of recommendation, within 6 months of it passing today, they have to go out for public comment. They would come back to the sponsoring committee and be evaluated. And I anticipated being able to go out for public comment quicker than 6 months.
So it can't be implemented until after that
It
time.
it can be it's actually the reason for the emergency action is so it
Okay,
can be
that's what I
implemented
thought.
now. And
Okay.
then, yeah, there's nothing, it won't be implemented today or tomorrow because we have to get the system in place to do it. And we want to make sure we communicate it to everybody in the community and that people are able to do it, but it will be implemented hopefully before the public comment goes out, although there's no reason to not move them along synchronously.
Okay, thank you.
Thank you. Any other questions or comments from the board? Doug?
Dr. McGee, I see no hands raised.
Right. With that, I will call for a vote.
The West Nile virus voting link is now available in your chat. I ask all board members to please cast your vote. The motion has carried, 24 approved, 2 reject, 0 abstain.
Great. Thanks, Doug. We'll work on communication regarding this. And as I mentioned, both the testing as well as the public comment. We'll keep the board informed of our progress on these issues. So thanks to the board for recognizing the need for responsible action to protect patient safety. So with that, we're going to move into the next item, which is the Finance Committee's recommendation for the FY 2027 OPTN registration fee. I'd like to thank Dr. Alan Reed and the Finance Committee, as well as HRSA staff and everyone who committed to this work. As was previously discussed during our May 21st meeting, a significant amount of analysis and discussion went into developing this recommendation. And before I turn it over to Alan, I want to remind the board that this action is both important from both a governance and a timing perspective. Specifically, the board's recommendation must be submitted to the Secretary of Health and Human Services this month for review and consideration. As you'll recall, we make the recommendation to the Secretary who approves it or who considers it for approval or not. And as a result, we need to take action on this item today. The recommendation in front of us reflects the anticipated cost of operating the OPTN in the structure of both the evolving multi-vendor environment, support for ongoing policy development and implementation of policies that have previously been approved. It provides the Secretary with our best assessment of the resources needed to effectively carry out the OPTN's mission for the next year. And with that, I'm going to turn it over to Dr. Reed to present the recommendation.
Thanks, John. Much appreciated. I think with that introduction, Doug, we can move to the last slide. No, kidding. The Finance Committee, the Executive Committee, the board have seen many of these slides before. But as this is an open meeting, the public may not be as aware of how we come up with the registration fee and what it takes to run the OPTN. So I beg the board's indulgence as we go through some of these slides again. If I can have the next slide, please. So this is how we got to today. The Finance Committee met in May to understand the costing methodology, ask questions, and give us time to answer those questions. And I'm going to show you some of that data in the slides as we go through today because they asked some very important questions. The Finance Committee met for a second time in June to reach a consensus on what the OPTN registration fee should be given that data and some updated information from our HRSA colleagues. That brings us to today, as John mentioned, with the important job of voting to approve or not our recommendations that will then get sent to the secretary regarding registration fee. Next slide, please. So again, I know many of you have seen this slide before, and we're going to dig into each of these buckets in a little bit more detail as we move forward. But there's essentially 3 cost buckets for operating the OPTN. This is what it takes to actually run the OPTN. And there's one divisor. So the first and the biggest cost bucket is what's demonstrated in the red boxes, and that's the contractual costs to actually operate the OPTN. Now, this is determined by HRSA. HRSA contracts through a standard governmental procurement process with a variety of vendors in this new multi-vendor environment that has been mandated by Congress. And we trust our HRSA colleagues to negotiate in good faith and get the best value for bringing all of this best-in-class operations to the OPTN. The board and the OPTN does not have much agency or any agency at all in these negotiations, but these contracts are made public once all the contracts are fulfilled. And the OPTN board does have some agency in responding to HRSA in terms of whether the contractor that's been selected is doing their job, good or bad, and whether there are additional operational items that need to be covered by an additional contractor or worked into those contracts. So that is far and away the biggest bucket. The next bucket of cost is shown in the blue boxes, and that's the anticipated cost of any pending new or unanticipated policy projects. It might come as a surprise to the public. It might come as a surprise to some members of the board that bringing policy forward actually has a cost associated with it in terms of looking at the data, analyzing the data, modeling the changes, and largely putting the changes into the computerized system. And in addition, recent changes to the Anti-Deficiency Act require us to have the entire cost of that project along its life cycle before we can approve it. That bucket we refer to as the new policy set aside. We're going to dig into that a little bit more going forward. And then finally, like all good organizations, we ought to have a bucket of reserve contribution for unanticipated items, especially unanticipated expenses like policies and directives. And as you'll see, currently we have none. And that's a conversation that the Finance Committee has started to take up in anticipation of the coming budget year. All those are added together and divided by the anticipated number of waitlist registrants. That was a function that the legacy contractor used to carry that is now calculated by HRSA using growth methodology. And the board and the Finance Committee in particular had a few questions about that methodology that I'll address when we get there. So that's sort of the overview. If we can go to the next slide, please. Let's look at the red bucket. This is actually what it costs to run the OPTN. And if you look at the left side of the slide, you'll see 6 different fee service categories. In each of those categories are specific services, and the OPTN budget for the FY27 year is depicted in the right-hand column. So board operations, including governance, administrative services, and indemnification through our incorporation, make up the fee service category of board operations. In terms of patient safety and policy, I'm really pleased to remind everybody that the membership and patient safety and compliance support contract was recently awarded, and that contractor is quickly getting up to speed with HRSA's help, and the board is looking very much forward to engaging with them. The only contract that has still not been filled but is currently out for proposal actively is the committee and program support for policy and compliance functions. That's a very important contract, and HRSA is working very diligently to try and get that filled, but that is included in the operating budget with an estimate best that HRSA can put in there. In terms of the customer member engagement, all of the public-facing communications, like the excellent new OPTN website, all the digital service, and the 24-hour call center are in there as well. In terms of data analysis and studies, one thing that the board should note is SRT operations, some of the operations, and some of their advanced analytics that used to be covered under a HRSA appropriation are now covered by the operations of the OPTN. And I should say the same is true for some of the public-facing items, as we'll talk about in a minute, that were developed under HRSA appropriation, but the long-term maintenance and care for those sites will be incorporated under this budget this year. Finally, the matching system and the IT infrastructure are also parts of this budget. And you can see that the total cost of actually operating the OPTN is $88 million. And if you go to the next slide, we simply plug that into the red bucket. And let's move on to the next slide, which is a little bit more complicated. So this is, pardon me, this is the new policy set aside amount. If you look at the box on the left-hand side, the current year that we're in is fiscal year 2026, and the available funding from the previous budget in the current budget year, or from the previous conversations for this budget year, was $6.5 million. Of that, a little under $2.5 million are already committed to board-approved, OPTN board-approved policy projects that this board is aware of and has voted on. In addition, we're required to carry out the secretarial directives, and in that bucket, I'm including any HRSA directors or board of directors sort of top-down directives, and that committed money is about a little over $2.5 million. Subtracting that from what was available, we have a credit of about $1.4 million in the current fiscal year that has not been spent. That gets moved over to the FY 2027 budget. You can see that credit on the bottom or the second to last panel in the box on the right. In terms of the FY 2027 budget, the box on the right, there are several policies pending approval by the board of directors, and several secretarial directives that we anticipate. And that's a little under $5 million, the $4.7 million. In addition, in conversation with board leadership and our HRSA colleagues, the Finance Committee has recommended an additional $5 million for new projects, unplanned directives, and things that we just can't foresee happening. I will remind the board that the executive committee under the leadership of George is currently, and I'd be remiss if I also didn't mention Christine, is currently finalizing a prioritization matrix so that we will have a better line of sight as a board into the priority of all the projects in flight. Adding those two together and taking the credit of $1.4 million, the new policy set aside recommended by the Finance Committee is $8.3 million. So the next slide. Oh, sorry. Yes. So the Finance Committee or the board, I can't remember which, asked us, and a very good question. They asked us, what would be the impact on the registration fee if we set aside different amounts? There was a very robust conversation about the different amounts of unplanned projects and unplanned directives and additional policy work that we would like to get done for the OPTN and the community writ large. If you look at the left-hand column, those are the different numbers we could plug into our equation: 2.5 million, 3 million, 4 million, and 5 million. And if you look at the right-hand side, and sorry to bury the lead with the bottom green box, but you can see that the total differential from the 2.5 million up to 5 million is a little over $30 per registration fee. So hopefully that answers the finance and the board committee's thoughts about what those changes mean in terms of real registration fee amounts. Next slide, please. So plug and play at the $5 million level, the new policy set aside is $8.3 million. If we can go to the next slide, please, let's talk about the orange box. In conversation with board leadership and our HRSA colleagues, we'd like to use the FY 2027 year as a baseline year, and we are proposing that we add nothing to the reserve contribution this year. However, the Finance Committee is deeply involved in conversation about what that should look like in FY 2028. How much operating reserve we should have. We're just trying to get an understanding of what our monthly costs are. It would not be unreasonable to consider 3 months of operations as a reserve, and that's pretty common in the business world, and how long it would take to get there and how to do that. But for the FY 2027 year, we are proposing zero addition to the reserve contribution. The other reason to do that is really to concentrate all of our finances on getting policies moving forward that have been stagnated for quite some time. So next slide, please. We add zero to the last box in the numerator. Let's turn to the denominator for a second, the anticipated number of waitlist registrants. Next slide, please. So this used to be a function of the legacy contractor, but HRSA has taken this over. And there were questions from the Finance Committee and the board, Executive Committee, about what the underpinnings of these estimates are. In fact, it's not all that complex. It's basically just a growth estimate looking at past growth. And so for the fiscal years 23 to 25, those 3 years, there was a pretty stable annual waitlist growth at 5.4%. And in fact, for the first couple of months of FY26, that held true. But from January to April of 2026, there's been essentially no growth. In fact, it's been pretty flat. And the May numbers confirm that. We don't have June numbers. I don't have June numbers yet, obviously, because we're still in June. But the May numbers confirm that growth has slowed. And so HRSA has adopted a more conservative growth forecast simply based on what the growth has looked like over the past several months. And rather than a 5% estimate, is estimating about 1.25% growth, yielding an estimated number of waitlist registrations at 76,033. You can see that's slightly higher than the FY26 estimate. Next slide, please. And if we put all those numbers into the calculation, we come out with a proposed registration fee for the board's consideration of $1,268, a little over $200 higher than the FY26 registration fee. Next slide, please. There are a number of reasons for this, and I think it's reasonable because we had, again, robust conversation around this at all of our previous presentations about the why. The community may be wanting to know why we had to raise the fee, registration fee in 26 and again in 27. Well, to start with, there have been no changes in the OPTN registration fees between FY22 and 25. Those 4 years were held flat. The reason it was held flat was because HRSA and the secretary asked us to spend down the reserve that had been created in prior years. You'll recall that the legacy contractor used to collect those fees and held that reserve. And that reserve has been spent down because while the fees have been held constant over those 4 years, operational costs have continued to rise. In addition, we haven't taken into account inflation, sort of the bottom point, whether it's general inflation or the cost of medical inflation, which is even higher. The operational costs have risen. The fee has remained stable, and the gap between those two were covered by the surplus funds. The surplus funds are now exhausted, and they were exhausted in prior year, and that's why we need to consider rebuilding that surplus going forward. Probably the easiest to understand reasons for this are the change in the OPTN cost structure. So as everyone's aware, the Securing the OPTN Act of 2023, in that act, Congress mandated that we transition from a single vendor environment to a multi-vendor environment. And that has been largely accomplished, save for a single contract that we're still waiting for HRSA to complete. And it's no surprise to anybody that multiple contractors bringing in best of class operations across the board is going to have some cost associated with it. But in addition, and as I mentioned, certain things that were previously covered under HRSA appropriations are now covered under the contract, the OPTN registration fees. That includes some aspects of what the SRTR did, including data modeling and analytics, and the board support contract. The board support contract was in its initial year a HRSA appropriation. It is now considered under the OPTN registration fee. And the goal ultimately is to get all of the OPTN costs under that contract. We already talked about the Anti-Deficiency Act, so I'm not going to go into that too much, but while it really increases budget transparency, it really requires us to have all of the costs upfront in order to do any policies. And we are working very diligently to get that prioritization matrix in front of you. It's ready to go to testing, actually. It looks quite good. We presented it to the Finance Committee just a week or two ago, and hopefully within the next month or two, we'll have something for you. And then finally, there's been a lot of new investment in infrastructure that HRSA has made largely through HRSA appropriations. And that includes the public-facing website, which I encourage the public to go to. It's really quite good. The OPTN 360 website, which is our internal communication site for policy development and communication, and ultimately for all the committees. And while that was paid for appropriations, the long-term management and maintenance, care and feeding of those sites will be incorporated under the budget. So that really summarizes the whys of why that number increased. Next slide, please. So I'd like to open it up for questions and discussion before we get to a voting resolution. Steve.
All right. I guess I'm have a question. I'm missing something. And you know this information so well, Dr. Reed. We said the reserve is 0 for the new coming year, but we talk about operational cost rising, inflation up, and the prior surplus having been wiped out. Does that make sense to have a reserve of 0 if those numbers are some are going up and the surplus is gone?
From a business sense, absolutely not at all. But from a public policy sense, we think it does make sense, and I'll tell you why. Thank you for that question. I have raised the same question as well with our HRSA finance colleagues and the Finance Committee. So it never makes sense not to have operational reserve in any business, as you're well aware, and the other business people on the call are aware. But I think I've said this before, and I think it makes sense. There was a transitional board before we were all seated, but I think, in fact, we are the transitional board. We are just trying to figure out this complex public-private relationship with HRSA. We're just getting our arms around all of the costs. And while I think it would be a good idea ultimately to start putting some money away, we thought we would use this year as a baseline year to understand the costs. Hopefully the costs won't go up too much going forward, other than perhaps an inflationary measure, because we think we're getting our arms around where we should be, at least at the moment. And then for the FY28 budget, there will be a contribution from the registration fee to go to a reserve. Just for the public's benefit, I want to just differentiate between the operational reserve and the policy set aside. There was some robust conversation around that at the Finance Committee meeting and the board meeting. Those are really two separate things. And that policy set aside is really intended for unanticipated directives, unanticipated needs, and additional policies that the board may want to move forward once we have a good line of sight into the prioritization. So thanks for that question, Steve. John.
Yeah, and while you said there was a difference between there, Steve, the policy set aside for future things, the 5 million, is a little bit arbitrary. So if we're going to go bankrupt because of lack of we could reprioritize. So there's nothing stopping us from.
All right. So
it's a little bit of semantics.
Saying we'll if we're short, we'll have to basically reprioritize what we might want to do, and then move forward in the next year with better understanding of the budget. That's
exactly.
Exactly. We, the board, I'll speak for the entire board, really, and the community, really want to see these policies move forward. That's why we put the $5 million in there for not only unanticipated things that might come down from the secretary, but also important policies. We were asked the question by HRSA, what policies do you see that, might be implemented in 2027? And my answer was, and I think I've made that same answer to the Finance Committee and the Executive Committee, we don't know. That's why this prioritization project is so critical to our understanding. And I think we're just a few weeks away from having that in play. Yes, Steve.
Yeah, and HRSA is on board with this. Because
Yes, they are.
obviously, if they were to propose a project that we couldn't fund, they would be obviously understanding that they're in agreement that we wouldn't have the money to go ahead with that project.
So
we understand. It's
Yeah.
Brianna from her, so we understand, and we're in the same rooms as all of you.
Okay, thank you.
Yeah, nobody speaks for Brianna, but I will speak for my conversations that I've had with all of the folks at HRSA regarding finance, and they understand that clearly. And they always have the opportunity to look for appropriations for things that we have to get done if we can't cover it in the budget. They are sensitive to that.
And there's nothing actually, there's both nothing stopping us, and it is our responsibility to look at all those line items as well, making sure we're as efficient and as effective as possible. So there could even be prioritization changes within those buckets if costs rise. So they're kind of, as Alan pointed out, their estimates, their best guesses of what it is, but we'll continue to make sure we make the most effective use of the funds available and don't spend money without good value.
And the other point I'll make before Steve makes it in a form of a question is HRSA is very sensitive to our need for better financial data as the year progresses. They have mocked up what I, for all intents and purposes, call an income statement. They're waiting for permissions to release that data, and been working very, very closely with Brianna and Mesman Germain to put that together. As you will all recall, one of the deficits that was uncovered in the initial projects that were awarded was that the board doesn't or hasn't to date had timely financial data with which to make good operational decisions. That will hopefully change within the next few months, and certainly by the start of the new fiscal year.
Great, thanks, Alan. Other comments or questions for Alan? Again, kudos to Alan, the Finance Committee, as he mentioned, to the Executive Committee with George, and in collaboration with the Finance Committees working on a prioritization matrix as well, which we hope to roll out in the near future. With that, I think the next slide is a motion that we have drafted. Therefore, be it resolved that the board has reviewed and discussed the fiscal FY 2027 OPTN registration fee proposal and hereby approves a fiscal year OPTN 2027 OPTN registration fee of $1,268. And this is to be presented to the Secretary of Health and Human Services for review and final approval. Can I have a motion? Thank you, Ken.
Second, Meyer.
Thanks, Dan. Any further discussion? Doug, I don't
I
see
see
anything.
no hands, Dr. McGee.
Okay, great. Well, with that, again, thanks to Alan and the Finance Committee. We'll go ahead and place a vote in the chat.
The vote for the OPTN fee is now in the chat. I ask all board members to please click on the link and cast your vote. The vote has passed. 25 approve, 1 reject, 1 abstain. Thank you.
Great. Thanks, Doug. All right. With that business conducted, we'll now move into the next portion of our meeting, which is other and new business. First, I want to give an update on a couple issues. Next. First, is with respect to visiting board member assignments. As you know, all board members are assigned to be a visiting board member to one of the OPTN committees. The plan is to keep those appointments unchanged for the upcoming term, beginning July 1. Typically, they had been, excuse me, for the term of the officer, which is one reason to not change them. Additionally, as everyone knows, this year has been particularly challenging with respect to the bridge period and other things. So there's both the some continuity, although very scant, because many people may have either participated in one or two meetings or perhaps none. So we're going to continue those assignments moving forward. For the next year. And then we'll, as part of the membership and bylaw and kind of assessment of things, we'll make sure we have a good structure about how that relationship is maintained. Again, the visiting board members are there to represent the board, not to add content expertise to the committee. That's why the committee is formed. So we'll continue those. The next item is regarding new committee members. As you'll recall, we previously had mentioned there were approximately 600 people who stepped forward interested in serving on an OPTN committee. Those committee appointments have now been completed. Notifications have been sent to the new committee members, and we're currently awaiting some final affirmance that they're going to participate. These confirmations, once received, will announce everyone who is new members of the committees. We are working with HRSA as well as board leadership to prepare onboarding activities in the coming weeks, which include both onboarding to OPTN 360, but perhaps more importantly, onboarding to the mission and purpose of the OPTN, their specific committees, and again, the specifics around what our fiduciary responsibilities are. I want to thank everyone who participated in the nomination and selection process. These committees are critical to what we do. We're very fortunate to have a strong group of volunteers that are willing to serve. Special thanks to the regional counselors and other members of the nominating committee who work through these large number of nominees and for selection. One of the things we're going to do is we're planning on holding one of the onboardings next week using the time previously reserved for the June board officer hour. As a result, we will not be holding the board officer hour this month. We're going to use that time to onboard those new committee members, or not entirely on board, but just to greet and give some brief orientation. And then the next item is regarding service on board committees. Board members have received a communication regarding the opportunity to serve on one of the board committees, which include the executive committee, the finance committee, and the nominating committee. If you have not yet responded, I encourage you to do so. I believe they're going to put the link again in the chat, or you can check your email. These committees are vital to what we do. The process is that these committees, once received, will be reviewed by board leadership with appointments. The executive committee is actually voted on by the board. I'd remind people that the executive committee in particular has membership parameters that need to be met as specified in the final rule. So that's one of the reasons to make sure that we have the right people stepping forward to be in these positions. Happy to chat with anyone offline about that if there's a question. And then finally, I meant to mention this at the beginning, but previously on the agenda was consideration for the appointment of an assistant secretary. I've made the decision to table that today, and we'll keep you updated on that. With that, I'm going to ask if there are any other business or new business before the board moves into closed session.
John, can I make one comment that I was remiss
Yes.
in not making because it was a question that was raised about the budget, about the fee?
Yeah.
And I simply passed over that. There was some concern from many of the patient and family representatives that the rise in cost of the registration fee would be a barrier to patient registration. And I want to remind not only my colleagues on the board, but folks in the community as well, that is not a fee that is assessed to the patient. It is a fee that is paid for by the transplant center. And as a pre-transplant fee, it can go on the Medicare organ acquisition cost report. And I won't go deeply into that issue, but I hope that explains that this increase in fee should not be a barrier to patient listing. It is not charged to the patient. It is not charged to their insurance company. And somebody asked the question, am I sure that that's the case at every center? Every center that is a transplant center ought to be taking advantage of the cost report. I can't attest necessarily to their practices, but they ought to be, and I would think that they are. Thank you, John.
Yeah.
And I'm remiss
Thanks, Alan.
in leaving that off.
Thank you. And I also know of no program that makes any effort to independently assess patients for listing. If any board member knows so, please speak, but okay, thank you. I don't see any other comments.
See no
With
other
that,
hand.
great, thanks, Doug. With that, I want to thank the public for attending today's meeting and let you know that the board is now going to move into closed session. Thank you for attending.